neonatal grave disease. These two conditions were chosen because indeed they are the source of a large morbidity and sometimes mortality, in particular in the case of neonatal grave disease that remains untreated in our neonates. This is a pretty important topic, and I'm very glad that we can address it today. We have received so far 538 registrations from 75 countries, showing that this is a topic that is relevant to many of us and is of interest quite globally. I will introduce Dr. Agustini. Agustini is a pediatric endocrinologist from Java in Indonesia. She's also the vice president of GPED, and together we are really working towards making GPED more and more relevant to you with topics that are totally relevant to your practice in countries where the access to care is sometimes limited. And I want to thank Arnetta and Anissa for their support in organizing this event. Thank you very much. Agustini, I will let you moderate and share the webinar, and thank you very much.
Thank you, JP. Good morning. Good afternoon, good evening to everyone joining around the globe. And welcome to the GPED World Thyroid Day webinar. My name is Agustini Utari and I'll be your moderator for today's important session dedicated to pediatric thyroid health, especially in settings where resources may be limited. This webinar is proudly hosted by Global Pediatric Endocrinology and Diabetes as part of our mission to promote equitable, evidence-based care for children with endocrine disorder worldwide. And today is a recognition of World Thyroid Day. We are turning our focus to a critical yet often under-addressed area, pediatric thyroid disorder in resource-limited setting. To begin our program, it is my pleasure to introduce our first speaker, Dr. Francisca Grob, who will be presenting on newborn screening for congenital hypothyroidism in Chile and South America. Our first speaker, Dr. Francisca Grob, a pediatric endocrinologist and assistant professor at the Pontificia Universidad Católica de Chile. She has extensive clinical and research experience in neonatal screening and thyroid disorder, with the training that includes a fellowship in pediatric endocrinology and research at the Murdoch Children Research Institute in Australia. Dr. Grob is deeply involved in the medical education, academic leadership, and professional society. She also a prolific author and invited speaker at both national and international conferences. Dr. Francisca Grob, time is yours.
Hello, everyone. Thank you so much for this invitation. I will share my screen now. Just a second. Sorry. Is this a correct presentation?
Yes.
Yes, okay. Hello, everyone. Today I will be talking about newborn screening for congenital hypothyroidism in Chile and South America, highlighting both progress and persistent challenges in our region and exploring its implications for low and middle income countries. So this talk will be structured in 5 parts. We'll begin with key concepts around CH and newborn screening, and then we'll review how screening has been implemented across Latin America, drawing on specific data in our country, in Chile. So the implementation of newborn screening programs in high-income countries from the decade of the 70s has led to earlier diagnosis of CH and improved cognitive outcomes. However, there has been a learning curve which has taken years to get to current outcomes. Because newborn screening led to cognitive outcomes within the normal range in children with CH, it has been progressively implemented as a public health program in high-income countries. Before the newborn screening, diagnosis for CH occurred at a mean age of 9 months of age with a mean IQ of 86, and 25% of these children had an IQ below 70. After the establishment of newborn screening programs, diagnoses were made as early as less than a month of age, with mean IQs rose to 105, and instances of IQ below 70 dropped to nearly none. Treatment doses have significantly increased from 6 to 10 to 15 micrograms per kilo per day as a starting dose, and the incidence has become more frequently detected, with lowering the incidence from around 1 in 6,000 to 1 in 2,500 cases. So the primary objectives of newborn screening includes the early detection and prevention of serious health issues in newborns. For conditions such as salt-wasting 21-hydroxylase deficiency, the goal is to prevent neonatal deaths. In the case of sickle cell disease, newborn screening aims to reduce infant mortality rates and decrease the overall morbidity associated with the condition. And lastly, for hypothyroidism, the screening endeavors to avert potential lifetime intellectual disability through timely diagnosis and treatments. These efforts are crucial in improving the quality of life and health outcomes of the affected children. So CH poses a significant public health challenge due to its impact on child neurodevelopment. Early detection through neonatal screening is essential for preventing intellectual disability and other long-term problems. For the Academy of Pediatrics, the priority of newborn screening programs is the detection of infants with moderate to severe primary hypothyroidism, which can lead to intellectual disability if not detected. As secondary priorities include the detection of infants with mild conditions or late-onset primary hypothyroidism, such as the delayed TSH elevation in premature infants, and central hypothyroidism. So alteration at any stage of thyroid gland development can result in congenital abnormalities in the development and function of the thyroid. Starting at the top, we have the hypothalamus, followed by the pituitary and the thyroid gland. Each of these structures depends on specific genes to properly develop and function. On the left side, we have genes involved in hypothalamic and pituitary development, in thyroid development, and on the right side, genes related to TRH and TSH signaling, and other genes related to thyroid hormone synthesis. As I said before, the main objective is to detect cases of primary congenital hypothyroidism. So to understand how newborn screening for CH works, we need to know the normal postnatal dynamics of thyroid hormones in healthy term newborns. In this graph on the left, we can observe that TSH peaks very early after birth, reaching values of 60 to 80 microunits per liter within 30 minutes after birth. This sharp increase is part of a normal physiological response to birth, and levels gradually decrease to normal between days 3 to 5 of life. Next, we see T4 levels, which reach their peak around 48 hours after birth. At this point, total T4 concentrations are around 16 milligrams per deciliter, and free T4s peaked to nearly 7 nanograms per deciliter. Unlike TSH, that runs down very quickly, free T4 takes longer to normalize. And finally, T3 levels also rise after birth, but this rise is less abrupt than TSH and T4. And what happens with preterm infants? So physiology in this group of patients is a bit different. On the left, we see data for extremely preterm infants, those born before 27 weeks of gestation. And the graph shows that the 99th percentile of TSH reaches approximately 40 microunits per liter, which corresponds to 18 microunits per liter of TSH in whole blood. On the right, we see the corresponding data for infants born later, after 28 weeks of gestational age. And in this group, the 99th percentile of TSH at 24 to 19 hours is lower, and then it peaks later and it rises later. So in newborn children, the physiology is a little bit different, with TSH having a lower peak after birth. It normally has a delayed elevation in some of them, and T4 in serum is low until 1 to 2 weeks of postnatal life. So in order to be able to interpret these thyroid hormone reference values, we need lots of information. like the postnatal and the gestational age of the child we are assessing, the variability of the measured hormones like T4, T3, and free T4, and which is the sample collection method. Also, if this child is has any comorbidities, because we know that the thyroid function is depending on the gestational age, on this immature hypothalamic and pituitary axis, the persistence of fetal peripheral diurnized metabolism, the thyroid gland is smaller, many times they have been exposed to iodine, they receive many medications, and also some of them are very sick. The good thing is that in many times they present with milder forms of CH that are very much more common in this population. Typically, they don't have any thyroid dysgenesis. This alteration in thyroid function is often transient, and there is still uncertainty about whether to actively screen these patients, how to screen them, and if they need any treatment at all. So apart from the children that weigh less than 1,500 grams or preterm infants, there are other children who should undergo a second sample collection. These are term newborns with any perinatal complications, or children who have been exposed to drugs like corticosteroids, dopamine, iodine, and thiamazole or methimazole. In establishing a newborn screening program and define a specific TSH cutoff for the screening of congenital hypothyroidism is not easy. Starting with a threshold of 50 TSH blood as a cutoff in the early programs, which were able to identify severe cases of primary CH, these TSH cutoff points at screening have been lowered over time in order to improve detection rates and because of changes made to assay methods in different countries. But reducing the TSH cutoff has caused a progressive increase in detecting additional mild forms of primary CH, mostly with normally located gland and shaped thyroid, although more severe cases of primary hypothyroidism have also been reported. In this slide, we can see the proportion of diagnosed children with transient forms of congenital hypothyroidism at a lower initial TSH threshold. If we look at the upper part of the slide, among those who had an initial TSH between 10 and 20, around 25% of diagnoses of CH had transient cases, compared to 48 to 65% of children diagnosed with primary congenital hypothyroidism, a transient form, when the TSH threshold is set at a number of 10. What happens in Latin America? So Latin America is an heterogeneous and not just geographically, but in terms of demography, health infrastructure, and economic development. As infant mortality rate has decreased, conditions like congenital hypothyroidism gain visibility within public health agendas. But the implementation varies widely by country, reflecting different levels of investment, capacity, and political will. Unfortunately, the implementation of newborn screening programs in low and middle income countries have been delayed when compared to high income countries, and many children within the region don't have access to newborn screening programs at all. So when a revision of the history and evolution of newborn screening activities in Latin America is made, it can be seen that the previously mentioned diversity also applies to newborn screening. Such diversity can be highlighted when analyzing different newborn screening parameters, like the year of implementation as organized programs, the modality of organization, the panel of diseases screened for, and the available technologies for testing. Also, and the coverage reached, the legislation in force, and the degree of development and success reached by every country. Taking into account all these parameters that I just mentioned, and despite that in practice a continuous spectrum of possibilities is found, the Latin American countries can be currently classified into 5 groups. So the blue group on top are countries with optimal fulfillment of these newborn screening programs, with high coverage and programs established many years ago. Then, in orange, we have countries going through a phase of growth and expansion of the newborn screening programs. Third, we have countries whose newborn screening activities were launched and implemented in the last decade with very variable numbers of coverage and not all the children being screened at the same time. And lastly, we have countries with minimal organized or non-organized newborn screening activities. So the Chilean newborn screening program prospectively collects data on children diagnosed with congenital hypothyroidism from the public health system, which represent 76% of the Chilean population, which is around 20 million people. We have 2 screening program centers that receive samples from 16 regions of the country and only collect data related to the diagnosis of the condition. It was initiated early in the 90s and actually covers 99% of the target population, obtaining samples from infants after the first 40 hours of life. So this is a summarized algorithm, and the one that we use in our country. And if the TSH screening value is greater or equal than 15 microunits per liter, the case is immediately referred for a confirmatory testing with a serum sample. If the TSH is between 12 and 15, the same sample is reanalyzed on duplicate on the initial blood spot. If the TSH is less than 10, the sample is considered negative, whereas if it's higher than 10, we need to obtain a confirmatory sample in serum. If the screening TSH is less than 12, the sample is negative and the child doesn't need any other samples. In order to get this program functioning, I will present you some of the characteristics of our program. First of all, there are 2 laws in place who have been created in 1994 and 2005, which regulate the creation and functioning of the newborn screening program, and that relies under the funding of 2 national health programs. Additionally, 2 national reference laboratories receive the Guthrie cards from the whole country, which include around 100,000 births per year and reach a coverage of around 99%, and measures the TSH in whole blood through the Philadelphia and GSP. The recall rate is less than 2%, and follow-up is organized locally at tertiary hospitals, which means that there are at least 25 centers treating the patients. Unfortunately, this program does not have a constant monitoring of the outcomes of the program and only sees the screening process. This graph illustrates the diagnostic incidence of congenital hypothyroidism in Chile from 1997 to 2023. Since the implementation of our program in 1992, the screening algorithm itself has remained essentially unchanged. The only modification over the years has been the methodology used for measuring the TSH. However, every methodological change has maintained the equivalence in TSH cutoff values to ensure continuity in the detection criteria. Despite this consistency, we have observed a gradual increase in diagnostic incidence over time. The mean incidence across this period is 4.9 per 10,000 live births, rising from 3.9 in 1997 to 5.7 in 2023. Here I summarize the strengths and weaknesses of the Latin American newborn screening programs after a workshop we held in 2021 with the SLEP, which is the Latin America Society for Pediatric Endocrinology. So among the strengths, many countries in the region have achieved high screening coverage and centralized sample processing, allowing for efficient analysis and timely diagnosis. In several cases, legislation supports the sustainability of these programs and public health funding ensures basic operation. However, weaknesses persist across all stages of this process. In the pre-analytical phase, coordination is often limited by fragmented health systems and geographic barriers. In the analytical phase, coordination is often limited by geographic barriers and constraints in reagent shortages that can delay the processing. And in the post-analytical phase, communication gaps, lack of patient registries, and uneven access to treatment and follow-up services remain major challenges. Addressing these gaps is essential to ensure equitable outcomes and long-term program sustainability in the region. So, which are possible approaches to a newborn screening program in regions where we do not have all the setup to be able to make these programs function? So, one idea that came up with a group of people, between them Dr. Givan Vitt and Dr. Odame in Canada, is to lag newborn screening programs to immunization programs, because BCG vaccination programs are widespread in low and middle income countries, with most children being immunized in the first month of life. One of the reasons why newborn screening lags behind immunizations may be that the collection of the Guthrie cards, which have to be sent to central laboratories, is not feasible in many low and middle income countries. So point-of-care testing, also called near-patient testing or bedside testing, is defined as medical diagnostic testing at or near the point of care, that is, at the time and place of the patient care. This contrasts with the historical pattern in which testing was mostly confined to the medical laboratory, which entailed sending off specimens away from the point of care and then waiting hours to learn the results, during which time care must continue without the desired information. So collection of a blood sample from the baby by a community health worker trained in POCT at home or at the infant's earliest visit for immunization may be the way of the future for newborn screening in low and middle income countries. For example, POCT for sickle cell disease is available and has been tested. However, this technology is still being developed for CH. In this context, since 10 to 40% of the population in Africa is affected by sickle cell disease, a study was organized a few years ago to test the feasibility of implementing a screening program for sickle cell disease using these devices, the POCT devices, within existing immunization programs in primary healthcare settings. Therefore, they screened children for sickle cell disease during their first well-child visit to receive their initial vaccinations, and they utilized available resources from their primary care system, incorporating a POCT device. Over a period of 2 years, they assessed children under 9 months old, diagnosing more than 50 children with the condition. So what happens with TSH? Evidence already exists on the use of POCT for determining TSH concentrations. This study in 2023 demonstrated high sensitivity and specificity in detecting TSH using POCT compared to a reference method, and no statistically significant differences were observed between the TSH values provided by FindCare, which was the name of this POCT, in venous capillary blood or serum samples versus the COBAS reference method. Here, in this Italian study, they also compared another POCT device with another reference method, also obtaining excellent correlation between both techniques. So, however, newborn screening does not simply involve testing, but it is a process that involves 6 stages and is generally organized and performed by public healthcare systems with the resources and authority to carry out universal screening. Each element of the screening process requires resources, training, standardized and accredited procedures, as well as quality controls. Patient advocacy ought to be positioned at the core of the system. Screening programs have been progressively expanding, especially in high-income countries, and often driven by family organizations. However, caution must be exercised regarding the partnerships formed between researchers, the pharmaceutical industry, and the patients. Today, some interests, often informally allied with advocacy groups, are at the forefront of efforts to expand screening. So to finish with the presentation, newborn screening for sickle cell disease and congenital hypothyroidism are essential in low and middle income countries to improve the health outcomes of those affected. Linking newborn screening to early immunization programs in low and middle income countries could have several benefits. First, it would allow for the efficient use of resources and infrastructure. Newborn screening for both sickle cell disease and congenital hypothyroidism in some settings could be done using the same blood sample, reducing the need for additional testing and saving time and money. Also, linking newborn screening to early immunization should increase newborn screening coverage. It is important that the vaccination is early enough so CH screening can be obtained before the first few days of life. Challenges to implementing newborn screening programs, including a lack of resources and awareness, must be addressed. Future research and collaborations between high-income countries and low-income countries could help to improve the implementation of these programs for sickle cell disease or newborn or congenital hypothyroidism in low and middle-income countries and reduce the burden of these conditions globally. So I would like to acknowledge and thank Dr. Ivan Bleed, Jean-Pierre Chanoine, Ana Chiesa for helpful discussions, as well as the local people of the lab, Dr. Gabriel Lobo and Susana Valdebenito, for always being very helpful and very nice conversations. I'm open to questions, and thank you very much for your attention.
Thank you so much, Dr. Francisca, for the informative and powerful presentation. Sorry. If anyone has questions, please drop them in the chat and we'll get to them during the Q&A. And I'm pleased to introduce our next speaker, Dr. Navoda Atapattu. Our next speaker is Dr. Navoda Atapattu, a highly respected pediatric endocrinologist at Lady Ridgeway Hospital in Colombo and a council member of the APES for 2025. She has led the development of national guidelines in Sri Lanka for managing conditions such as congenital hypothyroidism, rickets, and type 1 diabetes in resource-limited setting. And Dr. Atapattu is an accomplished researcher, educator, and international collaborator with numerous publications and active role in global endocrine registries. She is a frequent speaker at the international conferences and has been recognized with multiple presidential awards for scientific publication. Dr. Navoda, time is yours.
Thank you, Augustini, and good afternoon, good morning, everyone. My task is to talk on neonatal Graves' disease, practical approach for resource-limited settings. My talk will discuss how the fetus is affected by the maternal thyroxine level, how to diagnose Graves' disease in a neonate, and how to manage, and I will summarize at the end. So thyroid hormone, mother and the fetus. Embryo and the fetus need thyroid hormone for many developmental processes, including neuronal genesis, neuronal differentiation and migration, synaptogenesis, growth and maturation of organs. This embryonic thyroid gland produces small amount of thyroid hormone between 10 to 11 weeks of gestation. Fetal hypothalamo-pituitary thyroid axis becomes functional only after 20 weeks of gestation. Until then, embryo and the fetus depend on transplacental maternal thyroid hormone. Thyroid hormone levels can be disturbed by maternal thyroid autoantibodies, antithyroid drugs used by the mother for the treatment of hyperthyroidism. Neonatal Graves occurs in 1 to 5% of babies born to mothers with Graves' disease. Of course, maternal thyrotoxicosis is rare, and 85% of the maternal thyrotoxicosis is due to Graves' disease. And the incidence of neonatal Graves comes to 1 in 25,000 to 1 in 50,000, which is caused by transplacental passage of thyroid-stimulating hormone receptor antibodies. The onset of the disease may be from birth up to 10 days, and it can remit after 8 to 20 weeks. It is usually a self-limiting disease, but untreated fetal and neonatal Graves' disease could be fatal, and also it can lead to long-term complications like craniosynostosis, failure to thrive, and development delay. So who are the children at risk of getting neonatal Graves' disease? Those mothers who are on treatment for thyrotoxicosis and treated with antithyroid drugs, specifically who are having positive thyroid antibodies, those neonates are at risk of Graves' disease. And also previous maternal thyrotoxicosis treated with radioactive iodine or surgery, but the mothers continue to have antibodies within the bloodstream also will increase the risk of Graves' disease in a baby. If the TRAB titers performed antenatally after 20 weeks of pregnancy are more than 3 times the normal level or more than 3 international units per liter, or if there is any evidence of fetal thyrotoxicosis where fetal heart rate is more than 160, or if the fetus has a goiter, IUGR, or if you don't know the maternal thyroid antibody status, we have to take that neonate as an at-risk baby. And if there is a family history of neonatal thyrotoxicosis or very rarely TSH receptor mutations leading to severe neonatal thyrotoxicosis, we have to consider those babies also as having high risk of neonatal thyrotoxicosis. Little bit about these TRIBE antibodies. It consists of stimulating and blocking immunoglobulins. The risk to the fetus and the neonate is depending on the thyroid stimulating antibody titer. However, when you check TRAB, it does not differentiate between whether the thyroid stimulating or blocking antibodies and which proportions they are available. So the clinical features may be delayed for 1 to 2 months when the blocking antibodies are present. So there are reports of development of hypothyroidism as late as day 45. So we have to keep that in mind, even though the baby is not having thyrotoxic features. If you don't know whether the mother has thyroid blocking antibodies persistently for a longer period of time, then when the blocking antibodies disappear, the child will develop features of thyrotoxicosis. So keep that in mind when you follow up a child who is having a risk of Graves' disease or thyrotoxicosis. Clinical features, the goiter would be there if there is severe thyrotoxicosis, but particularly if the mother is treated with antithyroid drugs. Eye signs like periorbital edema, lid retraction, exophthalmos. Cardiovascular features like tachycardia, arrhythmia, hypertension, flushing and sweating, or congestive heart failure would be there in affected neonates. CNS features like microcephaly, irritability, GI features like weight loss, diarrhea, vomiting, hepatosplenomegaly, hematological complications like bruising, fatigue, thrombocytopenia, and jaundice are known to be associated with neonatal thyrotoxicosis or Graves' disease. Symptoms and signs may be present at birth, as I said earlier, but may be delayed for several days if the mother has blocking antibodies or if the mother was on antithyroid drugs. These could be the features of an affected baby with neonatal Graves. So the management depends on the biochemical as well as clinical features. All neonates who are at risk should get the vital signs 6 hourly assessed and also look for signs of hyperthyroidism. If the facilities are available, we can check the TRAB antibodies in the cord blood or in the infant soon after birth. That's the ideal setting. But in resource-limited countries, this may not be feasible. However, clinical examination and thyroid function test on day 3 to 5, on day 7, on day 10 to 14 of life will pick the children affected with Graves' disease. By day 14, if the baby is asymptomatic, biochemically normal, you can discharge the baby from the neonatal follow-up but explain the symptoms, what symptoms to look for, and to refer back if the symptoms of thyrotoxicosis present. Infants with normal thyroid function but raised antibodies should be followed up 2 to 3 months to ensure the signs of late onset hyperthyroidism. Remember, the thyroid functions can show, as Dr. Francisca explained elegantly, that high TSH and high free T4 levels during the first few days could be there due to no acute phase response. But when you couple the thyroid functions together with the clinical features, you will be able to identify the affected baby. So these are the reference values for children that you have to remember when you are dealing with a baby with thyrotoxicosis or hypothyroidism. So management, basically medical management, with the presence of clinical features of thyrotoxicosis such as tachycardia, wakefulness, and tachypnea, we may treat the patient with carbimazole and propranolol, and propranolol can be stopped when the tachycardia settles. If there is evidence of cardiac failure, we may have to consider glucose iodine and realiprednisolone in addition to carbimazole and propranolol. Carbimazole is given in 250 micrograms per kg 3 times daily, or methimazole 0.25 to 1 milligrams per kg per day. Methimazole is not freely available in most of the countries, but carbimazole is available. We do not give propylthiouracil due to hepatic failure. Carbimazole reduces the uptake of iodine by the thyroid and blocks the thyroid hormone synthesis by preventing the organification. And you have to remember, it is associated with some mild side effects. Those minor side effects should be explained to the parents. Those like purpuric rash, urticaria, gastritis, sore throat, arthritis. These are relevant for older children. And the major side effects could be agranulocytosis, which is rare. But these side effects should be explained whenever you start a patient with carbimazole, irrespective of the age. When you treat, mild, short-lived biochemical thyrotoxicosis can be followed up biochemically and clinically. However, if the TSH is suppressed and free T4 is more than 2 times the upper limit of the normal for the age, maybe more than 30 picomoles per liter, you may treat the patient with carbimazole and propranolol. When you start treating them, you have to titrate the medicine according to the clinical response. You can stop propranolol once patient is clinically euthyroid. You have to measure thyroid functions every 2 weeks and reduce carbimazole dose by 25% when the thyroid free T4 levels are normal. And you may continue dose reduction according to the thyroid functions fortnightly, aiming to achieve T4 in the normal range. That is free T4 of 6 to 30 picomoles per liter and the TSH level between 0.05 to 5. You may have to treat for about 8 to 12 weeks, and remember to do a whole blood count before starting carbimazole. And when the symptoms of fever, or if there is any evidence of infection, you may have to repeat the full blood count and also liver functions. All these children need head circumference monitoring as well as growth and development as any other condition that we follow up in a child. Who does not need follow-up? Those are the ones who do not have TRAB antibody, mothers who have been euthyroid without any antibody presence, and antithyroid drugs have not been used during the pregnancy. So those children do not need follow-up unless they have features to suggest thyrotoxicosis during the follow-up. This is just a small case which I came across a couple of years ago. This is a child this child was born to a mother with Graves' disease with eye signs, and she was on carbimazole 30 milligrams daily. And when the baby was born on day 1, free T4 and TSH was dead. T4 was 1.6 and the TSH was 1.51. By day 7, the T4 level remained 1.7 with a TSH of 22. And on day 11, baby's T4 went up to 3.2 with a TSH of 0.24. By day 14, free T4 was 3.9 with a suppressed TSH, and the clinical features. This baby required a small dose of carbimazole, and by day 14, the free T4 level came down to 1.8 and the TSH came back to 0.1. At that point, I reduced the dose by half and then stopped it. And by day 38, thyroid functions became normal, and on day 60, again, T4 and TSH was normal. Child's development and growth was normal subsequently. So in low middle income countries, we know that the TRAB measurements may not be freely available. However, the babies born to mothers with thyrotoxicosis or who have a history of thyrotoxicosis could be followed up biochemically with free T4 TSH and the clinical features. And remember, the breastfeeding is not contraindicated even though the mother is on carbimazole. These children need regular follow-up for growth and development. There may be other causes of neonatal thyrotoxicosis. So we have to consider if the neonatal hyperthyroidism persists, it could be due to a genetic mutation in TSH receptor. These patients require early aggressive therapy. They may not respond to antithyroid drugs. And sometimes this could be associated with McCune-Albright syndrome, where somatic activation mutation in the G-alpha gene rarely present with neonatal hyperthyroidism. So these two conditions should be considered when the baby does not have antibodies and the thyrotoxicosis persists for longer period. This is a baby who came around 18 months of age, referred to the pediatric endocrinologist. This patient presented initially to the pediatrician with failure to thrive and craniosynostosis with a TSH of less than 0.01 and a free T4 of 65 picomoles per liter. The pediatrician started carbimazole with advice from an adult endocrinologist. Child developed febrile neutropenia and they had to stop carbimazole. And at this point, baby was referred to pediatric endocrinologist. When the baby was assessed, we noticed microcephaly with an OFC of 33 centimeters, overriding sutures. He did not have any eye signs. There was diarrhea. Heart rate was 102. Prior to the referral, they have done the ultrasound scan, which showed mildly enlarged thyroid. Technetium scan was also done with no active nodules. TRAB antibodies were negative. TPA antibodies were high. And antithyroid globulin was normal. And when the patient was referred to us with the very high free T4 level, we had to start the baby on steroids, propranolol, and a low dose of carbimazole awaiting surgery. And 2 weeks prior to surgery, we had to give glucose iodine, and then the child underwent total thyroidectomy. Now he is on thyroxine. The picture was shown with the consent of the parents and the child. The points to consider are the first line therapy for Graves' disease during pregnancy includes antithyroid drugs. When you talk about children with Graves' disease, we cannot forget about the pregnancy and the pregnant mother. If the mother is affected, they need antithyroid drugs. And we have to maintain maternal serum T4 level at just above the upper limit of normal for the non-pregnant range. Otherwise, the baby will become hypothyroid. If the antithyroid medication is not possible, second trimester thyroidectomy is the treatment of choice, not radioactive iodine. Women with active Graves with a history of iodine treatment should get the TRAB antibody levels measured at 20 to 24 weeks to see whether the neonate is at risk. Usually, fetal ultrasound has to be done between 28 to 32 weeks if there is evidence of active maternal thyroid disease. In summary, any infant whose mother has a current or past history of hyperthyroidism is considered at risk. They should be identified. Measurement of thyroid TRAB antibody in the mother during pregnancy is important. If not, follow them up biochemically and clinically to see the features of hypothyroidism, to treat them early because it could be life-threatening even though it is self-limiting. If untreated, severe hypothyroidism can cause long-term complications. So this is the algorithm that we would like to follow. TRAB positive or unknown, and antithyroid drugs were used. Check the antibodies and TSH, take the history, If it is negative, low risk. If the antibodies are unknown and the TSH is abnormal, check again at 3 to 7 days of life. If it is abnormal, if the T4 is abnormal, you can treat. If not, check again at 10 to 14 days with a history and examination. If abnormal, treat. Otherwise, consider as low risk. Thank you very much for your attention, and this is my clinic at Gateway Hospital. Thank you for the opportunity.
Thank you so much, Nafoda, for the excellent presentation. So I'm certain our participants are eager to ask their burning questions. With that, we will begin our discussion session. Yeah. So we put the question in the question and answer here. So the question first is for, yeah, I think this is for Francisca. Is serum thyroglobulin reliable after thyroxine therapy has been started?
Thanks for the question. I'm not aware of any studies that follow up with the thyroglobulin. Thyroglobulin is a protein produced by the thyroid and is helpful at diagnosis to see whether there is or not any thyroid tissue. If we extrapolate this information with thyroid cancer patients in which giving thyroxine suppresses thyroglobulin levels, I would think that it's not 100% reliable. So if you want to use thyroglobulin as a tool to see whether you have or not a thyroid gland, I would use it at diagnosis before the initiation of thyroxine.
Okay. Yeah. And the second question. This one is from Dr. Anju Firmani to Francisca, I think. Can we request GPED as a global body to aim for increasing congenital hypothyroidism screening rates by promoting awareness of the option of cord blood sampling for TSH setting in local labs, focusing on the NBS with TSH more than 40? This option is low cost and can achieve almost 100% rate anywhere in the world. What is your comment, Francisca?
Yeah, I would like to thank Dr. Andrew for this very interesting question and comment. This is something we've been thinking of for a long time, many years. So the first thing is newborn screening doesn't work equally everywhere because not everyone is having their babies at hospital. So if you are in low or middle income countries in which the babies are being born in a hospital setting, this is a very good idea. However, there is only one screening program that I'm aware of in the world that uses cord blood, which is Finland. Finland has been using a cord blood TSH-based program since many years. It's a very successful program. They haven't changed. They cut off significantly over the years. They use a cutoff between 20 and they have been using between 20 and 40 over the years, which is not equal as the whole blood TSH that we use in Utricard samples. So the 20 to 40 threshold is equivalent to 12 to 25 TSH in filter paper, which is something that if you will be willing to use it, you would have to consider. And the Finnish program hasn't had any changes in CH incidence over the years with this program. I'm aware of other studies, one study in India in 2014, I don't know if Dr. Andrew participated, but they also screened around 500 babies and they set up which was the mean TSH in cord blood. But I agree that it would be a useful tool to identify children with a primary and severe congenital hypothyroidism, which is the aim of the newborn screening programs.
Okay, thank you so much, Francisca. And I think this is a very interesting topic about the TSH newborn screening in cord blood. Yeah. And the next question from Dr. Sahid Aziz. isn't it that thyroxine doesn't cross transplacentally and immunological antibodies cross and cause problem in grave? Yeah, this is for Navoda.
Of course, thyroxine crossed the placenta. That is how the baby's brain is being developed. When the baby's hypothalamus thyroid axis is not developed, thyroxine do cross the placenta and can affect the fetal brain and also affect the fetus. That is why we check for fetal thyrotoxicosis when the mother is having hyperthyroidism. Antibodies are also crossing, and these antibodies can affect the postnatal period. Thyroxine do cross the placenta.
Okay. So thank you, Navoda. And next question. At what postnatal age shall we do screening for normal baby? And I think this one is for Francisca maybe. At what postnatal age shall we do screening for one, a normal baby, and second for Down syndrome and other syndromes?
Okay, so thank you for the question. So for term newborn babies, the sample should be collected hopefully after the first 2 days of life, 48 hours, because this is when you will have TSH values already going down. But if you take the sample earlier, there are many studies showing that you will increase your false positive rate. So that makes your newborn screening program more expensive, and also you make many parents very stressed with the fact that the baby has a high TSH. So if you want to take like a Nutricard, it should be after the 2nd day of life. But if we are talking about cord blood TSH, that's different, because if you take the TSH very early on, during before the first 30 minutes of life, you won't have the TSH rise. So that would be for term babies. And for Down syndrome and other syndromes, you should follow up the same rules. You have to take the sample just after the first 48 hours of life. There are no data that shows that Down syndrome babies have a higher incidence of congenital hypothyroidism with the first screening samples. They have higher TSH on the follow-up. They have higher rates of hyperthyrotroponemia, but you should follow the same rules for any other babies born at term.
Okay, thank you so much for the answer. And the next question for Dr. Francisca. Why do we need to repeat second THH in term babies with admission to ICU, CDC, congenital heart defect, etc.? Any structure guideline to follow for this?
Well, thank you, Dr. Bushra, for the question. We need to repeat a second sample because when the babies are sick or they receive transfusions or where they are under medications, the TSH surge may be altered, and they may have an escape on the TSH surge and have the elevation of the TSH a little bit later. So if you have any of these variables, a second sample is needed. And these guidelines are supported by the American Academy of Pediatrics and the European guidelines for congenital hypothyroidism. We have 2 new guidelines. I think it's from last year or the year before, but if you Google that, it's for free, and you can have a look at that to see how to test the babies. Many countries have different regimes, but normally it's 2 weeks after taking the first sample.
Okay, thanks. Thank you, Dr. Francisca. And the next question for Dr. Atapatu. In a situation where propranolol is contraindicated for any reason whatsoever, what other alternative do you want to consider?
Thank you, Dr. Ibekwe, for that interesting question. Yes, there are situations where propranolol is contraindicated, particularly in conditions like asthma. In this situation, you may consider calcium channel blockers.
Okay, thank you. Other question Yeah, so the question is from Dr. Sahid. First is, doesn't T4 needed for first-time diagnosis along with THH and THH use later follow-up? And when do you use thyroid scan after biochemical diagnosis? I think this is for Dr. Francisca.
Yes, thank you, Dr. Shahid, for your question. Regarding testing for TSH and T4, we have to differentiate if we are having a screening sample or a confirmatory sample. So for the screening samples, most of the countries only get a TSH sample because the primary objective is to detect cases of primary congenital hypothyroidism. But there are some countries in Europe which their focus is also to detect central congenital hypothyroidism. And for that case, they also obtain a T4 sample for screening. On the other side, to get a confirmatory sample, it will depend on your resources. TSH is mandatory. T4 might be optional. I would suggest obtaining also a T4 sample because you can classify the severity of the hypothyroidism, so it's useful. And then for follow-up is also useful because, especially because at the beginning we are giving very high doses of levothyroxine, and what we see that after the first or second week of life, when you have initiated your high dose T4, you will see a raise in your free T4 level. So that's a tool that you have to adjust your thyroxine treatment. Also, it gives you other information about compliance. So if the resource is available, I would suggest to get TSH and T4 at follow-up. And regarding the thyroid scan, when do you use thyroid scan after biochemical diagnosis? It also depends on the resources. And I would suggest using it as well because that permits you to give you anatomical diagnosis. If you have a thyroid, if you don't have a thyroid gland there or you have an ectopy, it's very likely that this form will be permanent. Rather, if you have a normal thyroid gland at diagnosis, this might be a transient form, so it can guide you with a follow-up of the patient. And if you didn't have time to do that at screening, you can redo it at 2 or 3 years of age when you reassess the diagnosis of congenital hypothyroidism. Saying that there are many countries that are now not doing the thyroid scan diagnosis or at reassessment at the age of 3. This is very personal, but Canada and Chile, these are examples of countries that still do this exam.
Okay, thank you so much. And the next question, please. From Dr. Elizabeth from Nigeria. What level of THH cutoff is recommended for recall with cut blood using FIA measuring method? So this is for Dr. Francisca.
Yeah, thank you, Dr. Elizabeth. I'm very sorry, but I cannot answer that question. I'm not aware, and we do not use the cord blood program. So I would recommend to look at the Finnish program. There's a paper published a few years ago. They use a cutoff of 20 to 40, but I'm not aware of which method they use. I don't know if the FIA method. TSH cord blood values depend on many variables. One of them is the iodine sufficiency of the country. So that would be a first thing to know. And probably if you want to use cord blood TSH for your country, you should know, like, have a little study and maybe to get like a few samples and get a sense of what is your medium TSH, so you can set an appropriate cutoff so you don't get many false positives. But I couldn't recommend like a cutoff point. That's very personal.
Okay, so thank you. And the next question for Dr. Nafoda from Dr. Elizabeth from Nigeria. At what age did the second case have thyroidectomy? Does it mean the patient could not tolerate any anti-thyroid medication without neutropenia? Thanks for enlightening the talk.
Thank you, Dr. Elizabeth. Yes, the second patient could not tolerate carbimazole, even though we started with a very low dose of carbimazole so that the patient does not develop neutropenia. The free T4 level did not come down. There were so many risk factors to suggest that this patient would not respond to anti-thyroid drugs. One is very young age, male, and also the free T4 level to begin with was very high. So those were the reasons that we had to go ahead with thyroidectomy, and he had to undergo surgery around 2 years of age.
Okay.
Thank you.
Thank you, Nafoda. And we still have 4 minutes for the question. So the next question from Dr. Chandran. How frequent should TFT be tested in patients with neonatal grave disease if asymptomatic? Is there a specific protocol? Thank you. Yeah, Nafoda, it's your turn.
Thank you, Pranita. Yes, as I told initially, we up to 14 days, every third day we do T4 and TSH, and after day 14, if the patient is asymptomatic, and there are two ways to handle this. If the antibodies are negative, TRAB antibodies are negative in a resource rich country, you don't have to follow up. If you don't know the antibody status, maybe around 2 to 4 months of age, we will have to recheck free T4 and TSH levels together with the clinical features. There is no specific protocol, but those are the accepted follow-up measures in patients with neonatal graves. Up to day 14, every third day we do the thyroid functions, and after day 14, because of this late development of neonatal thyrotoxicosis due to antibody status, we will have to check them at 2 and 4 months of age. Recheck. Thank you.
Okay, thank you. There are so many discussion and we still have many questions also here. Next question, please. Okay, this one for Dr. Francisca. What about intrauterine effect on hypothyroidism in fetus independent of maternal thyroid acid? And the second question, if scan is missed at primary diagnosis, what is your protocol after brain development complete at 3 years of age?
Intrauterine effect of hypothyroidism in fetus independent of maternal thyroid function, I believe is the question. We know that maternal thyroid function is very important for the baby, because during the first trimester, the baby is not able to produce any thyroid hormones, and during the second trimester, 30 to 40% of thyroid hormones goes to the baby and are able to develop their brains. So, for example, in many countries, they test for maternal TSH during the first trimester to see whether they have or not hypothyroidism. And if TSH goes above a certain number, mothers get treatment in order to avoid cretinism or other forms of absence of thyroid hormones for the baby. So yes, thyroid hormonal function of the mother is very important. And the second question, the protocol for reassessing thyroid anatomy in cases of congenital hypothyroidism is something you can do after the second or third year of age. You can stop medication for a month if the baby doesn't have an absence of thyroid, or if the baby doesn't have an ectopic thyroid. Well, you will know, but if you stop the medication for a month, then you will expect for the TSH to rise. And in that case, you are able to do a thyroid CT scan, because the thyroid will be able to absorb the technesium and give you a result and see whether the child has a thyroid or not, or is it small, is it located in another part. So that would be the protocol: to suspend treatment and 4 weeks later to do the test, the imaging test.
Yeah. Thank you, Francisca. And the next question, Dr. Yuresa from Sri Lanka. When we follow up children with hypothyroidism who are on thyroxine, is doing THH enough, or do we need free T4 as well? Francisca.
Yeah, thank you, Dr. Yuresa, for the question. I think we addressed this question earlier. My opinion is that if the resources are available, you should test for both because they give you different information. It helps you to assess your treatment, to do some thyroxine escalation or going down with the dose. TSH, remember that it takes longer to normalize, especially in children that were diagnosed with a very high TSH. Sometimes you don't get a TSH normalization after the first 4 to 5 weeks of life. So during the first weeks of life, T4 is very helpful to see whether the dose you gave at the beginning is okay. So it would be something I would suggest to do.
Okay, and the next question. Yeah, this is for Dr. Nafoda. If a patient reacts to carbimazole, is there any recommended alternative? And second is it always necessary to add propranolol to carbimazole as a first-line treatment?
Thank you, Dominic. If a patient reacts to carbimazole, yes, it depends on how bad the reaction is. If those are minor side effects like rash, nausea, and vomiting, we may reduce the dose of carbimazole and still continue with that. These are self-limiting minor reactions. But if the patient develops severe agranulocytosis, like a neutrophil count less than 0.5 to 5 into 10 to the power 9, that is an indication to completely stop carbimazole, and because it can cause life-threatening infections and this severe agranulocytosis. Or if the patient develops hepatic failure or transaminases levels are more than 3 times, you will have to stop carbimazole. Then we will have to go ahead with alternative treatments. Those are either radioactive iodine or thyroidectomy. That again depends on the age of the child. If the age is less than 5, radioactive iodine is not indicated. If the patient is more than 10, you may go ahead with radioactive iodine. Between 5 to 10, you may consider, but preferably not. The better time to do give the radioactive iodine is more than 10 years. Otherwise, you have to get the thyroidectomy done by a very experienced surgeon in the country. The second question is it always necessary to add propranolol to carbimazole? What propranolol does is it reduces the adrenergic symptoms, tachycardia and flushing and all. So that because of that, we do add propranolol with the carbimazole until the free T4 level comes down. Once the symptoms disappear, we can stop propranolol. It is useful to treat adrenergic symptoms.
Okay. Thank you, Nafoda. I think we still have a question here. Next question, Arnita. Yeah, this is for Dr. Francisca from Dr. Samla, Sri Lanka. For a baby with congenital hypothyroidism secondary to anti-TPO antibody positive, when can we think of weaning off thyroxine replacement therapy?
Thank you, Dr. Shamla, for your question. First of all, I would like to say that congenital hypothyroidism due to anti-TPO antibody, it's very rare. It's not something common, and probably it's because the mother may have had another stimulating antibodies that also crossed the placenta. Also antibodies that cross the placenta and can produce these problems. So we should expect that the antibodies wean from the child's circulation earlier. For trap antibodies, the mean time is 30 to 45 days. For TPO, I think you should be testing and to see if you started medication, to reassess very often, probably every 2 weeks during the first months of life. And I would say that before the first 2 months of life, the child should be okay if that is the cause of the hypothyroidism.
Okay, thank you so much, Dr. Francisca. And is still any question, Arneta? Okay, we still have one question. In congenital hypothyroidism, if percent Stanley when repeated again and again, the age is 6 to 20 and T4 level normal and scan normal, can start the drug and observe the follow-up report?
Yeah, that's a very interesting question. It's the hyperthyroidopeninemia, which is a very common condition, especially now that in many countries we are starting to diagnose these mild forms of hypothyroidism, and there's a lot of controversy in the literature whether these patients should be treated or not. So first of all, we should think if this is a patient, how is the follow-up of the patient? If the TSH is rising steadily, of course, and the T4 or free T4 is going down steadily over time, yes, I would start treatment. But for example, if it's a down patient syndrome with a TSH of 8 and normal T4, I would think whether this patient would need therapy or not. So first, so 2 tips. I think it's important to see the follow-up, whether this is improving or not improving over time. And 2, what are the T4 or free T4 levels? And that's it. And also if it's an admitted patient, for example, if he's recovering for a sick euthyroid syndrome, sometimes you get like some peak TSH after being sick, or if the patient like thinking if it's a transient condition or not. Sometimes babies that have been exposed to iodine for studies like cardiac babies or other babies, but I would never take the decision only with one sample. I would follow and see what happens over time. We'll repeat it again and again. I think at some point you have to make the decision, and if the TSH is over 10 after the first month, what I do is that I start treatment. Maybe other people might think different. It's controversial.
Yes, thank you so much. And I think we still have the last question. What is your view on definitive therapy for hyperthyroidism? Can someone be on carbimazole for a long time and opt for no definitive therapy? From Dr. Samingan, Malaysia to Nafoda.
Thank you, Samina. It's a very interesting question. Yes, if the patient, as long as according to the medical literature, if you are on carbimazole for a longer period of time, the chances of remission are also high. So you may continue to take carbimazole for even more than 5 years if they do not want to go ahead with definitive therapy. But what happens is if there is a problem of the compliance, or if the patients relapse in between therapy, then you may have to go ahead with definitive treatment. We have to explain why we are going ahead with definitive therapy. That is because if you are not compliant or if you get repeated relapses. Otherwise, it is considered safe to continue carbimazole for a long period of time. Thank you.
Okay, thank you so much, Nafoda. And we had a very interesting discussion on cord blood for congenital hypothyroidism testing. So to further add more insight to our discussion, I will invite Professor JP and Dr. Anju Firmani.
Thank you, Agostini, and thank you, Dr. Virmani. I mean, for those who don't know Dr. Virmani, she's a pediatric endocrinologist in New Delhi. She's actually the founder also of the Indian Society for Pediatric Endocrinology. And to the best of my knowledge, and you can correct me, Andrew, is that India does not have yet a comprehensive national program, but we are talking about a country of 1.1 billion, I believe, inhabitants. So this is not a small task. and there are many, many barriers. But I mean, there are two very, very interesting papers, and I remember having read them published, I think, in the Indian Journal on the potential specificity of the screening in India, and this includes cord blood. And we do not have much of experience with cord blood, as Dr. Grob was mentioning, simply because in countries where there is such a structured system, we really feel that we are quite okay with the postnatal, and also iodine deficiency is less of an issue. So if you could very briefly share your experience in terms of the cutoff that you propose and the potential effect of iodine deficiency on this cutoff on cord blood in India, that would be great. Thank you so much for raising this important question.
Thank you, JP. Thank you very much. It was a very fascinating webinar, and I won't take very long because we are at the end of a long and tiring session. But in 2021, the Indian Council for Medical Research did a nationwide study in project mode looking for bright blood spot. And they were obviously interested in doing multiple conditions because CH is just one of them. And they found that in project mode, they could only get 75% of the children. And that's very similar to what Dr. Grob reported from Chile, that you can't get 100% children. Now, this is where systems are running well. But where you have systems in which you have remote areas and the Indian number is actually 3%. Only 3% of our children are systematically screened for congenital hypothyroidism, only in the very big cities, only in the very rich hospitals. So how do we reach across the country or across the world? And that is where we simply have to go back in time. Cord blood screening is what was propagated initially. And the difference in the last 50 years has been that TSH is now available pretty much across the world, and TSH is available very quickly. So if the cord blood is sampled and sent to a local lab, let's not waste our time sending it to a central laboratory. Reasonably accurate TSH would be available within 24 hours. Now, a big problem in countries like India and many countries in Africa is that the baby is discharged within 24 hours or even earlier. But TSH in the cord blood, which is not getting affected by the thyroid surge, will obviate all of those problems. So you've got a baby, the cord has to be cut, the cord has to be thrown away, you've got lots of liquid sample, no problem with sample being insufficient or the sample not being taken properly. And if we've got a TSH above 40, then the baby is simply told, hang on, don't get discharged. We will repeat your T4 TSH and the treatment can be started literally within 3 to 4 days of life. Whereas if the TSH is below 20, the baby is absolutely normal and can be sent home safely. So this is a system that if GPED were to propagate awareness of, now this doesn't need any government, it doesn't need any politician, it doesn't need any health program. If each pediatrician is covering the babies that are delivered under their care and just making sure that the nurse in the labor room sends a sample off, and the pathologist tells him the report before the baby is discharged, it's a very practical way of getting to close to 98%. So the hospitals in India, which are doing the cord blood, and we just had a paper in Indian Pediatrics in April of this year, we showed that it's very practical and it has good coverage. Babies don't get missed. And you can get anywhere between 95 to 98 or 99%. So this is a way that we can propagate simply with awareness, no money involved, no programs, no political clearances. The pediatrician simply asks the nurse in the labor room, please send the cord blood for TSH. And let's get the report before the baby is discharged. So that's how we can approach the 70% who are not getting screened.
Thank you very much, Angie. And I think this is the goal of these webinars, is also to exchange situations that are relevant to different cultures, different availability. And I'm very grateful for your comments. I will just give the microphone back to Agustini and Arnetta to finalize. And again, thank you so much.
Thank you so much, JP and Anju. Thank you for all our speakers for the insightful presentation, and to all of you who join us from around the world for this important World Thyroid Day webinar. Today's discussion have highlighted not only the challenges but also the opportunity to improve the diagnosis and management of pediatric thyroid disorder in resource-limited setting. At Global Pediatric Endocrinology and Diabetes, we remain committed to advancing equitable and evidence-based care for children everywhere. We hope today's session has inspired you to continue advocating the better thyroid health in your own community and clinical practice. On behalf of GPED, thank you once again for your participation, and we look forward to seeing you at our future events. Until then, stay connected and keep making a difference in children's life.
Thank you very
Thank
much,
you.
Dr. Agostini, as well as to all our speakers. On behalf of the organizing committee, we would like to extend our warmest round of gratitude to all our speakers and moderators for the incredible lessons and insights we have learned today. Of course, no event is complete without a photo session. We now invite all our honorable guests, speakers, moderators to turn your videos on, as well as to all our participants as well. Please turn your videos on. We will take a group photo with all our distinguished speakers and moderators. Let us give a few seconds for everyone to turn their videos on. 3, 2, 1. 3, 2, 1. 3, 2, 1. That concludes our photo session for today. So all the participants, kindly fill in the feedback form as detailed on the slides and has been sent via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. GPED conducts routine webinars as well as other very exciting opportunities for you. And currently, we are also conducting a global survey on the care of children and adolescents living with osteogenesis imperfecta. This initiative aims to better understand the current practices, challenges, and gaps in OI management worldwide. If you are a healthcare professional involved in the care of children living with OI, we invite you to participate in this important effort. Exciting news! Following the success of the first GPED annual meeting last year, we are proud to share that the second GPED annual meeting will be conducted on the 29th to 30 November and 6 to 7 December 2025 with the exciting theme of optimizing pediatric endocrine care in resource-limited settings, bridging assays, technology, management, and clinical practice. To keep you up to date, we also urge you to follow GPED on our social media platforms as detailed on the slide. Furthermore, register to become a member of GPED via the GPED website as seen on the slide. Once again, warmest round of gratitude to all parties who have made this webinar a great success. Thank you, and we hope to see you at the next webinar.
Thank you.